You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri, and I'm your host, Dr. J. Portnoy. It consists of a series of presentations by experts in allergy immunology and can serve as the didactic curriculum for trainees in the field. I hope you enjoy COLA. Take it away.
All right. Good morning, everyone. It's Conferences Online in Allergy. We're in Kansas City at Children's Mercy Hospital today. Our first topic for today will be asthma, and it's part of our summer series orientation. And this will be with Dr. J. Portnoy and Dr. Aarti Pandya. Thank you.
Thank you. I'm going to try to share my screen. Let's see here. Can you see my screen?
Yes.
Okay, great. Thank you. Thanks for letting us give our presentation this morning. I'm Dr. J. Portnoy. I'm a professor of pediatrics here at Children's Mercy Hospital in the Division of Allergy, Asthma, and Immunology. And Dr. Pandya, do you want to introduce yourself?
Thank you. Yes, I'm an assistant professor at Children's Mercy Hospital in the University of Missouri, Kansas City.
Right, thank you. I'm going to try to move slides forward. These are our disclosures, and these are the learning objectives for this presentation. Today we're going to talk about asthma. Asthma, in addition to allergic rhinitis, which is what we talked about before, is one of the key things that allergists do, and it's something that allergy fellows really need to have a good handle on management. And I thought I would start out by just asking several questions. And Dr. Pandya, maybe you can give your opinion about these. Do these patients have asthma? Because that's probably one of the biggest questions I get. Does my patient have asthma or not? What about a 6-month-old, several days of fever, wheezing, and retractions, and positive test for RSV, respiratory syncytial virus? Do you think this patient has asthma, Dr. Pandya?
I think based on the information given in that vignette, I don't think we can characterize that particular individual with asthma. And I think there's a couple of other diagnoses to take into consideration, as we'll discuss, like kind of generally what we need to diagnose asthma. Because it can be tricky. We don't have strict diagnostic criteria for the diagnosis of asthma, as we'll discuss in a later slide.
Yeah, it's a syndrome. It's not a disease. So it's kind of, you have to recognize the pattern of recognizable features that are together comprise asthma. There are criteria for it. Most people would call this 6-month-old bronchiolitis, which is just a keyword for asthma that happens in kids under 2 years of age who've not otherwise had asthma symptoms. That's how I think of it, but that's okay. What about a 2-year-old? They're having their 3rd episode of wheezing, coughing, and difficulty breathing, probably in association with respiratory infections, presumably, but 2-year-old with a 3rd episode now. What do you think about this patient?
I think, based on the diagnoses we have, or the labels of diagnosis we have, you could go a couple ways here. You can still characterize them as potential wheezing of infancy, as it's their 3rd episode. However, some individuals may consider that just a continuum of asthma. So I think I alone probably would not diagnose this individual with asthma, but there's certainly different ways to approach that.
And that's why there's 2 of us, because we have some slightly different opinions, and that's great to discuss. Personally, I think if somebody's having a 3rd episode, there's a very good chance they're going to have a 4th episode. The best predictor of future wheezing is previous wheezing. So the reason we call it asthma is so we can treat them for asthma. If you call it wheezing of infant, how does that really change anything? How does that make it better as a diagnosis? Why not just call it asthma?
Great point. I don't think it changes necessarily your management in terms of what you're going to prescribe them, especially if those are the complaints they're coming in with at the visit.
Yeah. So there's some controversy with the 2-year-old. What about the 5-year-old? He has persistent cough each fall, no history of wheezing, and he does not respond to albuterol when he's coughing during the fall. We see this sometimes, patients who just cough and don't wheeze. They don't necessarily respond to albuterol. What do you think about this patient?
So here, we certainly should consider cough variant asthma. There are individuals who may present with just coughing. Of course, you would do your due diligence here to make sure that there's not confounding rhinitis or acid reflux that you would need to look at. And in terms of their no response to albuterol, whether they were using a spacer or not, to have an appropriate response to their cough. But even beyond that, considering that wheezing alone is not a pathognomonic symptom for asthma.
Yeah, it's possible to have asthma and not wheeze, because asthma is a disease of inflammation. And the thing that causes cough is inflammation. Wheezing is caused by bronchoconstriction. So albuterol will help wheezing. It's not going to help cough. You need something to reduce inflammation. And then there's this 10-year-old. He has difficulty breathing only during vigorous exercise. Otherwise, no wheezing, no coughing, nothing else, just vigorous exercise, difficulty breathing. What do you think of that?
I think that it's something we certainly should evaluate. I think based on maybe that vignette alone, I wouldn't put the label quite yet. If it's a female, you want to make sure that they're not having a drop in hemoglobin, which is causing difficulty breathing during exercise or other confounding factors. However, it's certainly something that one should think about if they're presenting with those symptoms.
Yeah, and when I hear somebody who tells me that they have symptoms only during vigorous exercise, I immediately think of vocal cord dysfunction, especially if they don't wheeze or cough, and ask them, if you get a cold, do you wheeze and cough? Because you could have asthma and vocal cord dysfunction, but if there's no history of wheezing or coughing, even with colds, it's probably VCD. But you're right, you've got to get more information. I guess the bottom line is, what is asthma, right? What were we going to say?
That's a great point you brought up about vocal cord dysfunction. Studies that look at vocal cord dysfunction and asthma show an overlap of about 60%. 60% of asthmatics have some degree of vocal cord dysfunction. So it's certainly something to think about. But even in the absence of asthma, it's a diagnosis to consider as well.
Yeah, I mean, a long time ago when I was diagnosed, when I first learned about vocal cord dysfunction, there was this question of, is it asthma or vocal cord? It was like you couldn't have both. And the parents would get really mad if you said it's not asthma, it's VCD, because they also had asthma. So what we've learned over time is you can have both of these.
Absolutely. Yep.
So as we said, asthma is a syndrome. The definition of a syndrome is a set of recognizable features that occur in an identifiable pattern. That's the Webster's definition. And so instead of having a gene that we can sequence that tells us they have asthma or a specific biochemical marker for it, we have criteria. And if you meet the criteria, you have asthma. And if you don't meet the criteria, I guess you don't. Now, these are some criteria that were published in the literature. I know that because I was the one who published them. It basically has to be a lower airway obstruction. This is not nasal obstruction, nasal polyps. This is not upper airway obstruction. This is lower airway obstruction. It can also include upper airway. You can have croup, which is below the vocal cord. So technically it is lower airway, but maybe sort of medium in middle airway. But it doesn't include vocal cord dysfunction, which is technically above the vocal cords, or at least at the level of them. So that's not lower airway. Another feature of this obstruction is that it's variable. It's not fixed. It's not like a stenosis or a vascular ring or something or a tumor or something that's blocking the airways. It's a variable obstruction. When I was a resident, we would give albuterol, and if they didn't reverse in 15 minutes, they couldn't have asthma because asthma was reversible. The fact is, if you give them prednisone after 3 days, they will reverse. So you can't say that it has to reverse over a certain time period. It could be a 3-day time period. It could be a 15-minute time period. The bottom line is it changes. It's not fixed. That's the thing that we're getting at. And probably most relevant to that 6-month-old with RSV, it happens more than one time. So most kids who get RSV will wheeze. and that doesn't mean they have asthma. If they wheeze a second time, then that makes it more likely that they're going to have future wheezing, and therefore you might as well go ahead and call it asthma, because that way you can treat it. So I give everybody one episode of wheezing before I call it asthma, but once they've had it, then I usually call it. And notice age is not a factor. It doesn't say you have to be above 2 years of age. I see this all the time. Patients tell me, well, doctor was waiting until I was 5 before he could call it asthma. That's nonsense. That's not part of the syndrome. What do you think, Dr. Pandya?
Agreed. You don't have to meet a certain age to have that diagnosis. Individuals can use the modified asthma predictive index in different ways, and I think you and I have discussed that, even Dr. Portnoy. But that doesn't mean that you need to hit a certain age criteria to be diagnosed with asthma, particularly if you're having symptoms outside of illness persistently, chronically. It's definitely something to think about. And yeah, so I agree with you. Age is not, you don't hit a cutoff and then you diagnose someone with asthma.
Yeah, this asthma predictive index is interesting. It's often misused to just, people say, well, if you have to have this index is elevated, that predicts whether you'll have asthma. But you could have asthma today. That index is really a predictor of whether somebody who currently has asthma is likely to still have asthma when they're 5 or 6. That's what the index predicts. It does not predict whether you have it now. You have it now if you meet these criteria, right?
Absolutely. And just to review some of those criteria really quickly, if you have more than 4 wheezing episodes per year, that's needed for that particular index. And then you have to hit one major or 3 minor criteria. The major criteria includes a parent with asthma, physician diagnosed atopic dermatitis in the individual, or aeroallergen sensitization. The minor criteria being wheezing unrelated to colds, as we just talked about, eosinophilia on your CBC, and then patient who has a food allergy to milk, egg, or peanuts. And that's the modified asthma predictive index.
Right, and that predicts whether somebody who currently has asthma will still have it when they're age 5 or 6. It's not something you can use to tell whether they have asthma today. Today, the asthma criteria are listed on this slide. Why do we even?
Generally, we use that index in individuals who are 3 years of age or below. But like Dr. Portnoy said, if you're having persistent symptoms all the time, that index is not needed. It's only needed if you're having these intermittent symptoms and, you're using it in that context.
See if they'll still have it when they get older. Why do we diagnose it? Again, I would mention the best predictor of future wheezing is previous wheezing. And we also diagnose it so the patient can be prepared to treat the wheezing when it occurs. If they never wheeze again, you've prepared them, they never needed the treatment, no harm done. But if they do wheeze again, which is very likely, then they're ready to go.
And with that, asthma is our most common chronic disease of our pediatric population. So it is pertinent to diagnose them. There's always a question that comes into play: is asthma over or underdiagnosed? But the bottom line is, using some of the information that you presented in that earlier slide, having the appropriate diagnosis with the appropriate clinical syndrome is what's most useful for those individuals.
Yeah, I tend to err on the side of overdiagnosis because I don't think there's any harm in preparing somebody for future episodes. If they never have them, no harm. If you underdiagnose them, then they'll have future wheezing and not know what to do. And I think that's more harmful. And asthma has a lot of synonyms. I like to show this slide because I've seen asthma called all of these different things: bronchitis, bronchiolitis, wheezy bronchitis, verging on asthma. Oh, he'll outgrow it. That's what a lot of doctors say. And maybe he will, but he's got it today. And recurrent pneumonia. If I hear somebody who come in and say they have recurrent pneumonia, they have asthma that's just being called pneumonia. And then, of course, in pediatrics, we hear this all the time: reactive airway disease, which was used in order to not label the patient asthma because you didn't want them to have a pre-existing condition. But remember, with the Affordable Care Act, pre-existing conditions cannot be used as a justification for denying care. So it doesn't matter if the patient's been labeled or not. They can be called asthma and it doesn't hurt them. So how do you get a good history? We have a patient, we want to ask them history, and the first thing we need to know is about their symptoms. Do you want to go through the symptoms, Dr. Pandya?
Definitely. So the symptoms that can be present in individuals who have asthma do include coughing, indicating inflammation, wheezing, indicating airway obstruction, difficulty breathing, which may indicate both, and in older individuals, chest tightness. These are kind of your four main symptoms that you think about with asthma.
And I'd like to get an idea of how often the symptoms are present. That helps me determine how severe the asthma is. So if the asthma comes in episodes, it's usually being triggered by colds, then it's intermittent asthma. If they have asthma symptoms several days per week, then it's possible that allergies may be a trigger. If it's only in episodes, it's not likely to be an allergy because you'd have expected it would just be something that they're exposed to and then they're not exposed to between episodes. That doesn't make a lot of sense most of the time. If it's more persistent, several days per week, then that tells me that there's something that's triggering it more frequently and they have mild persistent asthma. And then if they have daily symptoms, then something in the environment is really triggering them. We call that moderate and sometimes even severe persistent asthma, but it kind of gives you a sense of what the triggers are likely to be if you know how often they're present. What do you think about the time course?
Yeah, so your time course can be, as we have identified here, seasonal, episodic, or persistent. Seasonal, you certainly want to think about allergic triggers, especially if it only happens within certain seasons. One other thing to think about is, if you have, and there's different allergens we think about, of course, with seasonal. So we'll talk about that a little bit later. With episodic, of course, infection can be one of the most common triggers in kids, especially when they're first introduced into a childcare setting like daycare. They're going to have an uptick of viral infections, and that can certainly be a time that they present with those symptoms. And then persistent, yes, certainly there's some type of potential ongoing exposure that's, triggering that individual to have chronic symptoms.
Yeah, exactly. So what are the triggers? Do you want to go through the triggers?
Yeah. We can have multiple allergic triggers. Of course, our pollens, including tree pollens, grass pollen, weed pollens. We know that those are different at different times of the year. Molds, we have both indoor and outdoor molds. And so we kind of think about both of those, especially depending on whether you're having more seasonal symptoms versus year-round symptoms. We know that those levels also fluctuate with humidity. Furry animals. I love that it's labeled furry animals and not just cats and dogs, because there's multiple animals that can trigger asthma. When we think of inner city or we think of people who live in apartments, you definitely want to ask about mice and rat exposure. You can, of course, own or have pets, including cats and dogs, which can be triggers of that. But then also you want to think about guinea pigs, gerbils, hamsters, all of those can be triggers. And then those who live in areas such as farming areas, horses can also be a trigger of symptoms, not exclusively, but there can be other animals as well. House dust mites, obviously a big trigger for asthma. Those are largely present inside the home, especially concentrated in our bedding as well as in stuffed animals. So if you have a child who's holding onto a stuffed animal that's never been washed or a blanket that's never been washed, so certainly something to think of, and they're having persistent symptoms, you think about it as well. And then cockroaches, again, especially an inner city trigger, and then rodents, I kind of overlapped that with furry animals. Irritants. So nicotine is associated with two things with asthma. One, the development of asthma in individuals who don't have asthma. And secondly, in individuals who have asthma, worsening disease than those who would not be exposed to nicotine. So it's a huge irritant. Pollution. We have had discussions about this in the last couple of weeks about how pollution impacts also pollination of your allergens. So it's kind of a double hit that you experience due to pollution. And then infections, big trigger, rhinovirus, RSV, multiple different viruses, parainfluenza had a recent uptick, so multiple infections that can trigger asthma. And then, of course, with asthma, you can also have coexisting conditions such as sinusitis, rhinitis, acid reflux, vocal cord dysfunction. And then you can have other triggers, including times of heightened emotions, including crying and laughing. Both of those things can trigger, having asthma. And certainly if that's happening, you want to think about the global control of asthma. And then lastly, exercise. So exercise is definitely something you want to address with asthma, because we know there's been recent studies showing that individuals who exercise with asthma have better outcomes than those who don't. But you also want to make sure you're optimally managed with your asthma such that your exercise is not limited by your asthma. So it's kind of something to think about in that global sense.
Yeah, I rarely write notes excusing asthmatic kids from gym class, for example. I think kids need exercise. A few other thoughts. I frequently have patients who come in telling me that their child has asthma that comes in episodes, about once a month or every couple of months. They'll have 1 or 2 weeks of episodes, and they want to know if it's the family dog. And I tell them, the family dog doesn't go away between episodes and then come back when your kid is sick. That just doesn't make sense. So the allergies, the exposures, and the symptoms need to correlate in some way. One other thing about infections, RSV, respiratory syncytial virus, is a very, very strong trigger of wheezing and coughing. Almost every infant who gets RSV will wheeze, whether they have asthma or not. On the other hand, rhinovirus, which is also very common, doesn't usually trigger wheezing unless you have asthma. And so which infection is triggering the symptoms is a good way of differentiating between kids who do and don't have asthma. Those who wheeze with RSV and not with rhinovirus probably don't have asthma. Those who wheeze with rhinovirus probably will go on to have future wheezing episodes. And this thing about acid reflux, there was a study done where kids who had acid reflux had it very strongly treated, and they compared the outcome of their asthma with and without the treatment. It made no difference. Acid reflux, I really doubt that that's a trigger of asthma. I think it's a separate disease that's often blamed for asthma, but I really don't believe that it's a trigger for it. There's a lot of people who have sinusitis who don't wheeze. So if you wheeze, sinusitis can be a trigger, but it's not causing your asthma. We have a bunch of tests. You ever do these tests? We have spirometries, we have nitric oxide. When do you do tests, Dr. Pandya?
Great transition into kind of talking about some general points. So, the challenging part about diagnosing asthma is that oftentimes when the patient presents to you, they're feeling well. They may not have symptoms. And so then individuals say, well, you have to be diagnosed with asthma based on a test that you may have, which we'll talk about what you can pick up on spirometry, which can indicate asthma. But the challenge is that despite doing these tests in the moment that the patient is in your clinic, these may not be abnormal because they may be feeling well. They may already be on controller therapy. They may have come with albuterol taken earlier in the morning or earlier in the day. So just know that while these tests can be good supplemental points to, aid in the diagnosing of asthma, they're not exclusively what you need to diagnose asthma. You kind of need multiple things together. When we think about the confirmation of diagnosis, there have been some key elements that have been outlined, especially in our guidelines, GINA guidelines, which we alluded to earlier, the demonstration of variable expiratory airflow limitation, which we see on spirometry when possible. The limitation with that is that, below a younger age, we use between 5 and 7, below that age, it is very difficult to comply with the technique that you need for spirometry. You have to be able to have a good seal around the tube of the spirometry, and then be able to exhale for that amount of time and comply with the technique that the respiratory therapist is demonstrating, is telling you to do. So generally, it's difficult to do that test below a certain age. Beyond that, going back to those 3 key additional elements, the second one is documentation of reversible obstruction, and the third is exclusion of other diagnoses. So generally, these have been outlined in our GINA guidelines for the confirmation of diagnosis with objective testing. However, like I said, those are not exclusive in terms of the diagnosis of asthma. You really have to use the clinical picture and then the tests as an adjunct. So spirometry measures expiratory airway flow. Also, you get some inspiratory, like you get your inspiratory loop picked up on, there we go.
Want to describe it?
Yeah, on it as well. I wonder if I can actually use my cursor.
Just
okay,
describe what you got.
Okay, yeah, I'll just go ahead and describe. So we have on the left side where it says volume, the top curve, we have our expiratory curve. So we have the forced vital capacity, which is the amount of air that's exhaled in liters over the time period that the patient was able to exhale. And then the first second of that is the fraction of exhaled volume in the first second. Your total lung capacity is based on both, your expiration and inspiration, and then your residual volume is the amount of air that is expired when your forced vital capacity has been completely kind of exhaled, which is kind of the different colors on here are showing. The bottom part is the inspiratory limb. So that, if we have some blunting of that, that can potentially indicate some vocal cord dysfunction. However, that alone is not diagnostic for vocal cord dysfunction. And then the curve we have on the right here is just something that's given to us with spirometry, which is the amount of time that the patient was able to exhale. So yeah, what did I miss, Dr. Portnoy?
Yeah, I kind of like this left one better than the right one. When a patient blows and they're blowing well, it kind of gives you this little pattern here. When they're obstructed, it gives you a scooped out pattern like the blue, and that's easier to recognize. On the right side, if the airways are obstructed, then the curve is flatter, but I'm not real good at judging how steep or flat a curve is. I just find that harder to assess. So that's why I kind of like the flow volume loop better than the volume time, but they both give the same kind of information. But what this is measuring is flow. This is just measuring obstruction of the airways that occurs when you blow out. If we want to know about inflammation, we have to use a different measure. Do you ever use FeNO or fractional exhaled nitric oxide in your patients?
Depending on the individual, sometimes it can be helpful, particularly if you are applying for certain biologics. This can be an adjunct to getting that particular biologic approved. Other ways that it has been used is whether there's compliance with your, inhaler therapy, although that can be difficult because you can still have persistent inflammation if you're not at your optimal dosage for your medication. The other thing to think about is that there is a lot of confounding factors for FeNO that you have to take into consideration, depending if you've eaten a nitrous meat related food prior to doing this test, if you have allergic rhinitis or not. So definitely those things need to all be taken into consideration when you interpret these values. Looking at the chart below here, we have different values that are outlined, both in your adult population as well as pediatric population. And you have different values that you use for high, medium, low, or non-elevated. Generally, when your level is 20, 25 or below, the likelihood of airway inflammation drops, as we see in this chart here. When you're in an intermediate range, it can be a little bit difficult to tell. You use kind of the general clinical syndrome with that potentially as an adjunct. And above 35 in the pediatric population or 50 in the adult population, you do have to consider, airway inflammation going on. So, I do think that individuals use or providers do use FeNO as an adjunct, either not necessarily for diagnosing asthma, but they can use it in the ongoing management for asthma.
Yeah, the bottom line is it's measuring something different than flow. You can have normal flow, but inflammation, and that'll cause you to have coughing, or you can have normal, no inflammation, but lots of airway obstruction, so your flow is decreased. So they're really measuring two different things. One thing I did want to point out about the FeNO, fractional exhaled nitric oxide. Nitric oxide is a substance that the cells in your trachea and in your sinuses in particular generate in order to stabilize and hold the airways open. It serves as a bronchodilator. This does not cause inflammation. This is something your body is producing in response to inflammation to try to reduce it. So that's something that people often mistake. They think that nitric oxide is the thing that's causing the inflammation. It's exactly the opposite. This is measuring your response to the inflammation. So just to kind of go back to the thing here, when and why should you do a test for asthma? I think you do a test to either help make or confirm a suspected diagnosis if you're not sure, or it can help you to determine the likely best treatment for the symptoms, because inflammation needs steroids, whereas bronchoconstriction may require more bronchodilators. Oftentimes you need both. And it helps you to monitor asthma over time. So if you have a patient who's really sick and they're getting better, this is a way you can use to monitor how much better they're getting and how quickly they're getting better. The bottom line is you do a test when the results will help you to make a decision about the treatment. My question is, and this is something that we debate all the time, is the so-called annual spirometry needed if the patient's doing well? They come in once a year. Do you have to do a spirometry?
That's a great question. So, and there's different answers depending on who you ask. In general, in terms of defining what it means to be doing well, does that mean they're not using any inhalers and they don't have a prescription, or do they have an inhaler, let's say ICS LABA if you're above 12, or just a SABA if you're below that age, and you use it once in a while, but really beyond that, you don't need anything else. CHEST guidelines say that it doesn't necessarily have to be annual. It can be every 2 to 3 years. But if they're not using any inhalers at all, you think about whether you need to do it at all. If they're not using inhalers and if they're doing really well, you then of course question whether they still have that clinical syndrome or diagnosis. But I think that is something we talk about, but there's not criteria that you have to do annual spirometry. Even based on
Yeah, I've never seen any studies that demonstrate that doing it annually improves any kind of outcome that you could identify. So I think it's something you do because it's routine, or you just do it, or I don't know why, but you do spirometry if you need to do it. If patient's doing well and you get a low spirometry, some of my colleagues will say, well, that means that they're not good perceivers. So I don't understand what that means. Does that mean that I have to tell somebody who feels well that they don't feel well? I think that's wrong. Don't tell somebody who feels good that they should feel bad. If they're poor perceivers or something like that. If they're feeling well and doing well and functioning, I don't care if they're poor perceivers. Let them poorly perceive. They're doing well. What's wrong with that? That's just a different point of view, and it's actually how I would want to be treated because I actually do have asthma. It's how I want to be treated. One other thing is you don't need a spirometry or a lung function test to make the diagnosis. I see patients come in all the time that are 4 and 5, and they say, well, the doctor wouldn't diagnose the asthma because I couldn't do the test. You don't need the test to diagnose asthma. The test is something you can do that may be helpful in addition to the clinical story, but you can diagnose asthma without doing a test. Okay? Let's move on to treatment. Notice we've spent half of our time on diagnosis. That's really rare. Almost every talk that I've listened to spends about 5 minutes on making the diagnosis, and then everything else is about all the different drugs and how much you give and how frequently and all that stuff. I think making a good diagnosis is probably just as important as the treatment. That's why we're spending half of our time on figuring out what you're treating before we actually throw treatment at it.
And also addressing some of the diagnostic challenges or issues that come up as well. So, yep.
So the thing that we need to keep in mind, and this is often misunderstood, is that the initial treatment is based on the severity of the asthma, and that's a specific thing that's defined in the NIH guidelines. Subsequent treatment is based on control, not on severity. Theoretically, once you put them on treatment, they should have no asthma symptoms. So how do you define a severity? You don't. Basically, you define how well controlled they are and use that to either increase or decrease or stay the same in terms of your treatment. This is severity. Do you want, we don't spend too much time on this because it's really complicated in detail, but can you just kind of give us a few kind of salient features about this table that we see all the time?
Absolutely. And those who rotate with me in clinic know that I kind of use this in terms of good teaching points or talking points. When we're classifying asthma and then kind of at subsequent visits talking about the control of asthma, as you indicated, Dr. Portnoy, the things that we're looking at are what are outlined under components of severity, which say impairment and risk. So all of the things that are under impairment talk about the degree of which your asthma is impairing either your daily activities, nightly activities that we'll talk about. And then your risk is the risk of exacerbation that is there due to your asthma, which can help determine the next part, which is step, how you determine treatment for those. In general, impairment is determined by daytime symptoms, nighttime awakening due to asthma symptoms, use of what we have here is SABA therapy, but also ICS-LABA therapy in older patients, interference with normal activity, and then your lung function. Those are all of the components of your impairment. And we all frequently refer to this chart, if we're making the initial diagnosis or talking about, whether they're controlled or not. And then we look at risk in terms of how many exacerbations that they've had in the past year, which can be defined by oral corticosteroid use, hospitalization, frequency of ER visits. So yeah, I think those are kind of the main highlights of this chart. And this chart will look different depending on if you're 0 to 4 years of age, 5 to 11 years of age, or 12 years of age and above.
Yeah, I think it's interesting that we're taking something as complicated as asthma and categorizing it into 4 categories. That's kind of condensing a lot of information down into a very small set of categories. And I don't think of these as criteria so much as characteristics of people who have different severities. So you really shouldn't use these as mandatory things or criteria. They're characteristics. The reason I say that is, for example, I have asthma that occurs when I get a cold, just intermittent asthma. Between colds, I have nothing wrong with me. I've done spirometries, I've done FENOs, I've done everything. I have nothing wrong with me until I get a cold. If I get 1 cold a year, I have intermittent asthma. But if you look at the exacerbations under risk, if I have greater than 2 in 1 year, I'm suddenly moderate persistent. And I've had colleagues tell me that I have to use an inhaled steroid every day of the year for year in and year out, when in fact I just was unlucky enough to get 3 colds that year. The rest of the time I'm totally normal. I don't need an inhaled steroid every day year round because I had 3 colds. So you can see how this can be very misleading if you follow it too carefully as criteria. These are not criteria, these are characteristics. You need to use them that way. Bottom line is intermittent asthma just happens in episodes. Between episodes, you're okay. I don't care how many episodes you have. That depends on how many colds you got. Moderate, mild persistent is asthma that happens several days per week. Now, something is driving your asthma enough that you have persistent symptoms. So this suggests more of an allergy possibly, or something in the environment that's triggering you, but you've got ongoing inflammation that may need some treatment. Moderate persistent means you've got a lot more inflammation, you need more aggressive treatment, and severe is, well, severe.
And if I can make, oh, perfect, we have another chart about this. Can I make a couple points about this? So, I would say that generally exacerbations are no longer used to put an individual in that category, in one of those categories that you talked about. Secondly, we have FEV1 and FVC listed here, and we have this 80%, 60% listed here. However, is some thought process now of using percentiles, 5th and 95th percentiles with z-scores, as opposed to just using, 60%, 80% for some of these numbers. So just one other thing to think about as that information continues to evolve.
Yeah, so if you've got a patient who's being treated, technically they should be well controlled. So you can just maintain their treatment. If they're not well controlled, that means you're not doing enough to control them, so you need to do more. And if they're really poorly controlled, you need to do a lot more. That's kind of how I use this. If they're really well controlled and having no symptoms at all, I often will ask, can I reduce the treatment? In fact, maybe I'm giving them too much treatment. So that's where asthma control comes in. And it's not the same thing as severity. You can have all different severities and either be well controlled or not well controlled. So control just tells you how to go from here once you've put them on treatment. Dr.
Portnoy, one question that comes up with allergists is, when do I de-escalate my therapy, as you were talking about? What time window do you use?
I'm a lot more aggressive about de-escalating than I would say than any of my colleagues. I will just make that claim. As soon as the patient's well controlled, I de-escalate. This idea of 3 months, that's nonsense. Once they're doing great, try to reduce the treatment. That's what the patients are going to do anyway. It's what I do. I'm not going to take medicine if I don't need it. I don't think we should tell patients to take more medicine they need. I think that this idea of waiting 3 months before you give them permission to reduce their treatment, they've already done it before. They've seen you and they come to see you to see if what they did is okay. They're not asking if it's okay to decrease it. Occasionally, some really compliant parent will do that, but most people don't want to take medicine and if they don't need it. So we need to rethink this de-escalation very slowly thing. That to me, that's just wrong. I don't know. And I guarantee I de-escalate faster than anyone. We do have this asthma control test. Do you use this?
Yes, this is one of our validated scoring systems that we use. It's a little bit different depending on the age of the patient. And under age of 4, we use a very similar score called the TRAC score. And then above age 4, we use the ACT, or asthma control test. It's a patient-driven questionnaire that they fill out, and it gives you a score, which you can use to help, determine if your patient is having good control of their asthma or not. Generally, we say a score 20 or above indicates good control. Under that, you evaluate a little bit further. However, sometimes parents are not fully paying attention when they fill this out. So just because you have a low ACT score doesn't mean you automatically say, okay, time to change the inhaler. They can say that, you know what, I marked it this way because my kid actually had a cold in the last week. Okay, well, if that's the case, then you don't necessarily escalate therapy based on your ACT.
Yeah, I find it's good to have the patient fill this out before the visit because it gets them to thinking about these questions so that when I ask them the questions, they've already thought about it and can answer more efficiently and maybe more thoughtfully. For the most part, the ACT I use as a just so story. If the ACT is really high, but the patient's doing poorly, I come up with some story to explain why that might be the case. I don't really use the ACT to control my treatment. I use the patient's symptoms, how they're doing, and then I try to match the ACT to that. And if it doesn't match, I make up a story, but it doesn't really drive my treatment. So I know that there's all this data and everything, but I've just not found it to be that useful to drive the treatment, but it is useful to prompt the patient so that they think about how they're doing. These are medication. Let's talk about treatment. This is what everybody's waiting for. Let's talk about quick relievers. We've got albuterol is a quick reliever. By the way, some people call these rescue medicine. Do not call them rescue medicine. Rescue means you're about to die and we have to throw a life raft and rescue you. I don't think we should let patients get that sick. Instead, we use these to relieve symptoms when they have them. We're not rescuing them, we're relieving their symptoms. I just emotionally feel that that's a better approach. We have albuterol. It lasts about 4 hours. It has a rapid onset, about 5 minutes. And then we have formoterol, which also has an onset of about 5 minutes, and it lasts a bit longer, about 8 hours. And that's why formoterol is called a long-acting beta agonist, as opposed to albuterol, which is called a short-acting beta agonist, or SABA. And then ipratropium technically is a quick reliever, but I think very few people use it as such.
Levoalbuterol can also be a quick reliever, and Dr. Portnoy is correct. We generally steer away from the term rescue, and even our NHLBI guidelines and GINA guidelines recommend the use of the term quick reliever. So levoalbuterol can be beneficial in those individuals who have symptoms with albuterol and formoterol, such as rapid heart rate, things like that. So. However, levoalbuterol, unfortunately, is on a national shortage, so dealing with those issues.
The evidence that levoalbuterol is better than just regular albuterol is pretty iffy. I mean, I used to give talks for Sepulchre, and so I have that conflict. I don't talk for them anymore. I don't even know if they exist anymore. But the data was really was missing, and so they had to interrogate the data so much that eventually it confessed a few findings, but for the most part, it was pretty minimal. I think of them as pretty much the same thing. It's used for wheezing, tightness, and difficulty breathing. These are treatment of bronchoconstriction. They do not treat inflammation, so they don't work for cough. I have patients who come in and say, my child coughs all the time, albuterol doesn't help, so he can't have asthma. That's nonsense. They cough because they have inflammation. Albuterol won't treat inflammation, so they don't need albuterol. They need something for the inflammation. The other thing is regularly scheduled use of albuterol doesn't really help. Sometimes if the patient's getting worse, they're told use your albuterol every 4 hours. It should always be used as needed. You can actually develop tachyphylaxis if you use it regularly over a long period of time. That means it becomes less effective with ongoing use, so it's not recommended. Any other thoughts?
That is correct, and we'll talk a little bit about yellow zone, but even regularly scheduled albuterol in the yellow zone, we have seen studies time and time again say that doesn't reduce your risk of exacerbation. So
don't do it.
Yep.
Long-acting beta agonists, LABAs.
Yes.
There's 2 LABAs that are available in the United States. There's formoterol, which is quick acting and lasts about 8 hours. And then there's salmeterol, which is slow acting, takes about 20 minutes to take effect, but it lasts longer, about 12 hours. And I think there are others also, but I've never used them, so I can't really tell you what they are. And I'm not saying they're no good. I'm just saying I've never used them.
If I can add one of those on there, one of them is called vilanterol. It is slow acting and it has a duration of 24 hours. Generally, when vilanterol is prescribed, it is prescribed in an ellipta device, whereas formoterol and salmeterol can be prescribed in an MDI device, in a discus, or in a RescueClick device.
My guess is I haven't used other drugs because they're probably not approved for kids, and I only treat kids. These last longer than short-acting beta agonists, and they're often used in combination inhalers with an inhaled steroid. Early on, salmeterol was available as a single agent, and there were concerns that it might actually make asthma worse, even asthma deaths. So now you can only get these long-acting beta agonists when combined with a controller like a steroid. Formoterol, by the way, is used in smart therapy we'll get to, and salmeterol is not a quick reliever, just reiterating that. Anything else about LABAs?
That's everything, and then vilanterol is also not a quick reliever either.
Exactly. What about leukotriene modifiers, montelukast and zafirlukast? What do you think about? Do you ever prescribe montelukast to your patients?
Personally, I do not use these medications a lot, especially for asthma. We are recently seeing this big black. We knew that these medicines were associated with behavioral side effects, which were then, put on a black box warning. Even when we look at the studies of intermittent, leukotriene receptor antagonist used in yellow zone therapy, it's not been shown to make any significant reductions in exacerbations. So either I personally scarcely if never use it as asthma management on a chronic basis, and I definitely don't use it on an intermittent basis for yellow zone therapy either. What about you, Dr.
Exactly.
Portnoy?
Well, I think they're marginally effective, and they do have side effects. Suicidal ideation and night terror is what you said, but if you look at the package insert, the most common side effect is headaches. And I can't tell you how many kids I see who are followed in the migraine headache clinic, and I tell them, well, maybe you could try stopping your glucotriene modifier. And they do that, and then they no longer have migraine headaches. So it's amazing how often that happens. This is not a totally benign drug. It used to be vitamin S. Everyone was put on it. It doesn't hurt. Why not? Try it. If it doesn't help, stay on it anyway. We don't do that anymore. Okay, we've got inhaled steroids, and I wrote many others, and I'm sure Dr. Pandya, you can list half a dozen other inhaled steroids I've never heard of and don't really want to know about. At one time, these were always recommended for daily use. Nobody did that. In fact, there is a full literature on the fact that patients will not use these on a daily use. They use it when they want to. Compliance is terrible, but we used to do that anyway, and the doctors and patients would fight with each other over it. And there's also the NIH guidelines has page after page after page of minute differences between them and doses and all of that. I think that's silly. That's just my opinion. What about for very young children? They use these very low doses and they don't work. I think young children take smaller breaths, and the amount of medicine delivered is equal to the concentration times the amount. And the breath is so small that keep the same concentration. I never use the lower concentration of an inhaled steroid. I always use the higher concentration because kids take smaller breaths. They're getting less of it. So there's no sense in that. And it's never actually been shown to be something that was necessary. And basically, more frequent dosing is more effective than increasing the number of puffs per dose. I've seen patients who come in on 4 puffs twice a day or 6 puffs twice a day. Nobody with asthma can take 6 puffs of anything. It's just, it makes you short of breath. It's exhausting. You want to increase the frequency, not the number of puffs. Those are my thoughts about steroids. What do you think?
I will highlight a couple of points as well. So firstly, these different steroids can be available in different formulations. For instance, fluticasone propionate versus fluticasone furoate. So look at that a little bit when you're prescribing those. Secondly, the device can be different. You can have an MDI device, you can have a digihaler device, you can have a ellipta device, a twisthaler, a flexhaler, a discus, or a readyhaler. So there are different devices that you can use for inhaled corticosteroids. Dr. Portnoy brought up an excellent point. What about intermittent ICS dosing versus daily ICS dosing, especially when we're talking about yellow zone therapy? So we know that intermittent ICS dosing for pediatric population has been shown to reduce the risk of exacerbation in asthma. However, in the pediatric population for yellow zone, doubling, quadrupling, quintupling has not been associated with reducing asthma exacerbations. In adults, quadrupling inhaled corticosteroids has been associated with reducing asthma exacerbations. And then we know that SMART therapy, single maintenance and reliever therapy, has been associated with decreasing that risk as well. So knowing that you can use these and increase these in yellow zones, but knowing that in your pediatric population, the data looks different than the adult population. Lastly, one point that Dr. Portnoy mentioned, compliance. There were recently some studies that came out that demonstrated that pediatric population, that compliance is better if you dose these once a day. Not saying that you can't dose it once a day, but just generally the compliance increases if you increase the dose and then put it as once a day, as opposed to having a smaller dose and then doing it twice a day. So it's something you want to think about based on that knowledge we have in studies.
Yeah, I'd say almost all of my patients are on once a day treatment when they do take it. I only increase it to 2 or even 3 times a day when they're having an exacerbation. Nobody can take an inhaler twice a day and on a long-term basis. It just isn't going to happen. As somebody who uses an inhaler, I can tell you that that's true because I won't do it twice a day and I'm pretty compliant with my medicines. Combination inhalers, we're kind of running short on time. We're not going to finish, but we'll get what we can. These are the combinations that are available in the United States. and only the ICS with formoterol can be used for smart therapy. Usually these are prescribed for more difficult patients with asthma, but I would like to briefly get to these other things. We're not going to talk about biologics today. That's a topic for a different thing. And by the way, allergy shots technically is a biologic, but this is going to be something for a different presentation. I do want to mention briefly spacers. What do you think about spacers, Dr. Pandya?
When we are using MDI devices, the recommendation is to use a spacer to help increase delivery of your medications to your respiratory tissue. So I use them in individuals I prescribe MDI devices for. And then on one of those combination therapies, just wanted to point out fluticasone bulanterol is also one of those. Anyway, sorry, back to spacers.
I'm sure there are many of those. And
back to spacers. Fine. So yeah, so those who I prescribe MDI devices, I do prescribe spacers. This is one here on the slide is one that has a mask on it, which we use for the pediatric patients. And then as they get older, there's a different one that doesn't have a mask when they're able to form a seal around the spacer with their mouth.
Yeah, I kind of did a thought experiment a few weeks ago where I was thinking if I beamed back to 1985 when I was training and tried to treat asthma, would I be able to do it? Because it was terrible back then. But I thought, well, we had inhaled steroids, we had inhaled bronchodilators. If I knew what I know now in 1985, I would do so much better. The problem is we did not have spacers back in 1985, so I don't know that I could do any better. Spacer is critical. A patient comes in with asthma and they're not doing well. First thing I ask is, are you using a spacer? And if they are using it, I have the respiratory therapist observe them using it to see how they're doing, because a lot of times technique is poor. It really, really is required. And as someone who has asthma and uses an inhaler, it always helps. There's no age above which you don't need a spacer. It always improves delivery of medicine into the lower airways. It's something you really have to do. Okay, these are the treatments. I don't really want to spend too much time on that other than to mention that this is the therapy that we're currently using for intermittent asthma, inhaled short-acting beta agonist as needed, for mild persistent low-dose ICS or leukotriene modifier, and also consider ICS as needed, or perhaps ICS formoterol as needed. This is so complicated, and we've only got a few minutes left, but do you want to briefly describe your initial long-term therapy for patients?
Yeah, and I just want to also point out that step one, if you're above the age of 12, the new GINA guidelines recommend the use of an ICS or a low dose ICS, excuse me, with formoterol. And generally, I follow this in terms of how the patient is initially presenting. So it just depends on how the patient initially presents. But, I've certainly used a combination of all of these different therapies that are outlined here.
Just keep in mind, this is initial therapy. Once they're on therapy, you're following control and you're increasing or decreasing from where they currently are. So just to finish up, we started with attitudes, and I think we need to see what the attitudes are. This is what patients have said that they agree with. And the most common attitude is, I want to take treatment that provides immediate relief. They want to get well fast. But they want to use the medicine as and when necessary. They don't want to take it every day. They know how to do it well. They know well enough to intervene early to try to prevent it from getting worse, and they want control. That's why when I hear things like quadrupling the inhaled steroid doesn't control yellow zone or control asthma, I don't care. The patients want it. They want something to control their asthma. Whether it works or not, they feel out of control. They want control. The purpose of doing this, of giving them the treatments and explaining how they work and what to do, they will experiment with it. And they will find out what works for them and do that. That's why I don't ever tell a patient what to do except right at the beginning. I usually ask them, what are you doing? And is that working? And if it is, I tell them to keep doing that, whatever it is. I'm not going to tell them what to do based on some guidelines because the patients really want to control their own asthma. Any final thoughts about this? And we'll probably have to pick this up again in our next presentation of asthma. We'll continue this one, but any thoughts about this, Dr. Pandya?
No, Dr. Portnoy, you summarized it pretty well.
Yeah, I mean, I have asthma. I use my inhaler when I want to. And if we look at adherence when the patients are well, about half of them are compliant. About a third of them take less medicine than you tell them to because they don't think they need it. And some people are really paranoid. They take more medicine than you tell them to. I don't quite understand that, but that's what happens. When they get worse, when they get sick, patients become more compliant. Compliance plus goes way up. You tell them increase it to twice a day or 3 times. They're going to do it 4 or 5 times a day. They're going to do what it takes to control their symptoms. So patients' compliance actually helps them to better control their disease than we could by giving them guidelines. We just need to give them the tools, tell them how to use it, and let them figure out what works for them. That's sort of my attitude. Anyway, I think we have to stop here. Any final words that you wanted to say before we close? And I'm going to skip forward to the final slide so that we can say goodbye, and then we'll continue this discussion at another time. But let me just go to the last slide because I thought that was a pretty slide.
Yes. Thanks for picking a good picture of me, Dr. Portnoy. One last point I wanted to make about compliance is that, you know, if there are challenging issues with compliance that you're dealing with your asthmatics, you want to think about any confounding factors that may be leading to that. Barriers with transportation, with cost of medications, and we can certainly talk about that in the next time we talk about it. Are there any questions from anybody before we hand over COLA to our next presenter?
I just want to say thanks for that great presentation. I love the format where it's kind of going back and forth here, a little bit more lively than what we see in some of our talks. So I appreciate that part too. At a time, I'm not going to ask this, but it's sometime I think we need to talk about a little bit more about exercise-induced bronchospasms and some of the things that are more consistent with that than just shortness of breath, which is what we're going to hear a lot of. So anyway.
Great
Yeah.
point, Dr. Miller. And thanks for having us here.
Obviously, asthma is a topic that takes more than an hour to review, and so it should be a two-parter. But we'll resume where we left off in a future presentation.
Sounds great.
So thank you.
Thank you too.